Welcome back again after the coffee break. Uh, I have Dr. Srija, who is one of my senior colleague here, who started this patient and got the initial hemodynamics. This is a lady of around 35 years, identified to have a large atrial septal defect, severe pulmonary hypertension. You'll see the PowerPoint.
Yeah, good morning all. This is 35 years female, mother of 2 children, was having complaints of breathlessness on exertion and occasional chest pain since last 6 months. On examination, weight of 36 kg, saturation is 98%, first heart sound is normal, second heart sound is wide and fixed split, there is loud P2 and there is pansystolic murmur at left lower sternum border. ECG shows QRS axis of plus 120 degrees, so there is right axis deviation with incomplete RBBB pattern and STD changes in right precordial leads. X-ray shows CTR of 68%, cardiomegaly, right atrial enlargement, MP and branch P's are dilated and there is no pleural effusion. So this is apical 4-chamber view showing massively dilated RA-RV. RA measures around 6 by 6 centimeter and there is mild RV dysfunction. Again the apical 4-chamber view showing moderate TR, RVSP is 105 plus RA and there is large 24 millimeter ostium secundum ASD which is shunting left to right. IVC is dilated measuring 19 millimeter, collapsing minimally with the respiration so these are the T images showing large ASD which is shunting left to right with deficient retroaortic margin. This is the NFAS view showing 3D reconstruction of ASD. So final diagnosis is large 24 millimeter ostium secundum ASD with deficient retroaortic rim shunting left to right, RA-RV dilated, severe PH with RVSP of 105 plus RA. So this is the basal hemodynamic data which you got. SVC saturations of 57% and IVC of 65%, and there is a step off from SVC to PA saturation being 81.6%. In the pressures, RA pressures of 18 A waves and mean RA pressure of 14. RV is 90 systolic with EDP of 16. PA pressures are 100 by 40 with mean of 58. Pulmonary veins 14 and aorta being 140 by 100 with mean of 125. So basal QP is 6.8 liters per minute, QS of 2.6 liters per minute, QPQS of 2.6, PVR is 6.4 Woods unit, SVR is 69.2, PVRI is 7.9 Woods unit meter square, and SVR is 48.3 Woods unit meter square. So plan is ICE guided fenestrated ASD device closure after oxygen study.
Okay, so an interesting, challenging case, Shiva, one that we're faced with fairly frequently, and in particular in Asia and Far East. Bharat, you're an expert on these. What do you think of the hemodynamics and the size of the ASD?
Show the PowerPoint once again.
I think as far as this patient is concerned, I'm quite optimistic. I think given the fact that the baseline shunt is so good, given the fact that the pulmonary artery diastolic pressures are just 40 and the mean pressure ratio is almost 2.5:1, I think I would be happy just closing this ASD and starting the patient on pulmonary vasodilators.
So you wouldn't do balloon occlusion, test
no, I don't think that in this case I would really consider doing anything.
Okay.
I think looks good to me.
Okay. Dietmar, is that what you would do as well, or?
For me, it's a clear indication to make a fenestrated ASD occluder.
Yeah, but you would go straight for closure.
Yes,
you wouldn't do anything else.
Fenestrated.
Yeah. And Nick?
I would go for a fenestrated ASD occluder. Yes.
Zaid?
I think this is something to discuss. The PVR in the instruction for use for these devices is less than, I don't know, the PVR has to be less than 8 Woods units, and then it says you can close it. This patient has 2.6:1 left to right shunt. His PVR is 6, right? You can see that on the screen. So the question is, why do we need a fenestrated ASD device in this patient?
I wouldn't.
You can do this case with a regular ASD device. Put him on antipulmonary hypertensive therapy for 6 months.
Okay, what's your backup plan if things go wrong with the pulmonary artery pressures?
I don't think
fall.
if the data is correct, things should not go wrong.
Yeah, but if they do, what's your backup plan?
But the point is the following, and we all know that if you have elderly patients, 60s, 70s with an ASD and these wood units, then you say, this is a long-standing left to right shunt, etc. That's a young lady. And even at her young age, she has 8 wood units, 7.9 wood units times square meter or meter square. So this means there may be, in addition, not only the left to right shunt as underlying.
Right. Would you then close this straight off with a normal device without balloon occlusion, testing pulmonary artery pressures and so on?
I would absolutely go forward and close this defect.
Shaq, we have really looked at our data in this particular subset of patients. These are young adults, and this subset is very commonly seen in India and other eastern part of the world.
Yeah.
These are young adults who have significant pulmonary hypertension, and some of them come with a very large baseline shunt and have a low pulmonary artery diastolic pressure and a very large anatomical defect.
Yep.
These are the patients who are known to do very well following their closure on pulmonary vasodilators, with most of them pressures dropping to less than 50%.
Yeah.
In the long run.
Is this 24 millimeter ASD out of proportion to the amount of pulmonary hypertension, do you think, or not? Is this compatible?
I think that in this subset, I have a reason to believe that a part of this pulmonary hypertension is flow related, and you will see over a period of time, once you cut down the flow, the pulmonary artery pressure will drop.
In the audience, show of hands, those who would close this defect with a normal, non-fenestrated device. Normal. Okay. Good. And those who would use a fenestrated device, well, that's very helpful. Shiva, it's 50-50 for you.
Okay.
So you'll have to phone a friend now.
Shaq, I want...
Shiva, you're going to do what you're going to do.
Shaq...
Shiva, hold on. Jae Young's got a question or comment to make. Jae Young?
It's a comment. I believe that most of the patients like this doing well after closure. But in very small portion of patients, they may show some aggravation or less improvement after closure. So we should be careful. If you close 100 patients like this, and if you experience 3-4 patients who have a significant residual pulmonary arterial hypertension, it's going to be a problem. So I'm definitely close with the fenestrated.
Okay.
Another short comment. It depends where the patient come from. If he's from high altitude, I would definitely with fenestration.
I suspect this is low altitude.
Yeah, it is a low altitude.
In South India. Yeah.
Most of the places in South India are of low altitude.
Yeah. Kanan?
See, in my opinion, fenestrated ASD device helps only in those patients who develop high LA pressure following ASD device closure. That is, who have high LV.
High LA pressure
following ASD closure, large ASD. So the fenestration helps them in reducing the LA pressure and preventing the immediate post-op pulmonary edema, but not in such cases. These cases, either you decide to close or not to close. If you decide to close, it's a regular ASD device closure. I will go for regular ASD device closure.
Okay. Regular. There are two reasons to have an...
hold on, Nick. Yeah, we'll come back to this. Shiva, because otherwise we'll run out of time.
Shaq, the proponents of direct ASD closure, who without any fenestration, were also adding one more caveat. They said that they will give 6 months pulmonary vasodilator, 1 year pulmonary vasodilator. Why then? Why do you want to give? So that means there is an ambiguity of the decision-making process. That means there is a role in partially closing it.
Not 6 months, Shiva. They may require pulmonary vasodilators lifelong. And believe me, even with your fenestration, don't think that they are not going to require pulmonary vasodilators.
So if there is a role for pulmonary vasodilator, do you think there is a role in partially fenestrating them rather than completely closing? Show hemodynamics live.
I'm not saying that don't do it, but I would, in my practice, given this hemodynamic data and this clinical
hemodynamics
picture,
live.
would not hesitate closing the defect completely.
Let me get you to do things whilst we're discussing as well, because otherwise we won't progress.
Yeah. Okay. I think one important point to consider is what were this patient's saturation 6 months ago before you started him on pulmonary vasodilator therapy. This patient has pure left to right shunt. So I am not sure why you need a fenestrated ASD device.
Zahid, this is the pulmonary artery pressure after 20 minutes of oxygen now.
The pulmonary. What was the 6 months ago at rest in
No,
air at home?
saturation
or
even
in
today
the
is
clinic?
normal, 98%. Even today is full.
Normal.
Normal.
Okay.
Is it spontaneous breathing?
Hello?
Spontaneous breathing, the patient?
Oh,
It is a normal sinus rhythm.
yeah, we can hear you. Yeah, is the patient on ventilator or spontaneously breathing?
Spontaneous breathing. She's just on mask oxygen.
Okay.
Okay.
She's fully conscious,
okay.
fully breathing on her own, listening to our conversation.
Okay.
Relax.
Okay. So there we are, 100% or oxygen treatment. There's the pulmonary artery pressure. What do you do?
92, 37, 56.
Again, what?
What will you do now? He's showing the pulmonary artery pressure in oxygen.
Yeah, in oxygen, I would never use oxygen for testing a patient with a shunt with oxygen because all calculations are wrong afterwards. So I would look, as Barrett have mentioned it, to the diastolic pressure gradient is 0.4. Thus, the patient have a reactivity of the pulmonary artery system. I can see it by the numbers. But again, why an ASD patient becomes symptomatic? Why a patient becomes symptomatic in 60 years,
Right.
in 30 years, in 20 years.
Very quick, very quickly, because we're already in the other lab.
Right.
So,
See, there is a very wide pulse pressure in the pulmonary artery.
yep.
So it's majority are flow related. The diastolic pressure is so low. I am sure once he closes the ASD, on table itself, our systolic pressure will be much lower than 93.
Okay. Right, Shiva, Tin is pushing us as well, so we need you to either make a decision or proceed.
Sure. Okay.
So what are you going to do?
I see the pulmonary artery pressure at the end of 20 minutes of oxygen is not showing any reduction in the PA pressure. I agree that there is a 2.6:1 left-right shunt. The basal PVR index is close to 8 wood units. I feel that this ASD should be closed with a fenestrated device because you can always
Thank you.
go back and if you want to enlarge the fenestration, do it.
You are right.
Yeah. Shiva, go for it. We know you're going to do what you're going to do, so that's okay.
But also, this is controversial in many ways, isn't it? As shown by the show of hands, it's 50-50.
Yeah. You know, I mean, you're not going to listen to guidelines or
Physiology is not democratic.
No, Zahid, let us make it clear. On what guideline you are stating that you want a complete closure on this ASD when the pulmonary artery pressure is not showing any
Shiva,
fall?
don't shout. Shiva, don't shout. Turn the volume down and then carry on. Yeah.
The thing is that we are not saying it on guidelines. We have our own data.
Yeah.
And I have now 9 patients whom I have followed for over 5 years. And this is what has happened. And this is the exact subset. Large hearts, young adults, large baseline shunts, low PA diastolic pressure, and anatomically large defects. And they have done brilliantly, believe me.
All of them?
Okay, another quick comment. Shiva, you keep going ahead. Don't stop. Go ahead.
I just have a comment with regards to the conversation that's going on, because I think fundamentally there's a little bit of a difference between a primary left to right shunt, increased PVR, and pulmonary hypertension versus this particular unique subset of what we call as ASD-associated pulmonary hypertension. These are patients where you have some baseline pulmonary hypertension. They also have an ASD. They present a little bit earlier, and those are the ones that have a problem with regards to what we need to do, whether to go what Bharat is talking about as a lifelong pulmonary vasodilator, or what Shiva is talking about with regards to fenestration. I think the jury is out there. I don't think we have an answer for that, but I certainly think there is a separate entity where you have ASD-associated pulmonary hypertension.
I think the bottom line here is that both approaches are correct. There isn't anything forceful about one versus the other, and therefore neither is wrong. So let's, Shiva, keep moving.
Yeah. Get the sheet. Ask them to show the echo live. Not our faces, echo live. No, echo 50%, fluoro 50%, hemodynamic 50%, not our face, not the camera. They're gone to the other center, yeah. భయం లేదమ్మా ఈశ్వరమ్మా ఈశ్వరమ్మా భయం లేదు రిలాక్స్ ఆక్సిజన్ కెన్ బి డిస్కనెక్టెడ్ focus on the device.
So what have you done so far?
See, the echocardiographic measurement of this hole was around 23 to 24. So we decided to use a 27 Occlutech fenestrated device. We normally don't...
27 Occlutech fenestrated.
Yeah, are you able to see the fenestration?
Yep.
I'll show my finger.
Take your hand away. I think we see it better without your hand.
Okay, fine. But
there you go.
But let me tell you one thing. I will now sheath it inside and then show you after
what size fenestration is this?
6 millimeter. 6. So now I am getting it opened again. Now you see that sometimes the fenestration doesn't fall in place properly. And
Shiva, the patient is watching too.
Yeah, she's watching.
So she's being mindful of that.
She's very interested in the fenestration. So you're loading a wire alongside the device, yes?
Correct, correct. In order to get the fenestration coaxial after we get the device across. So now this goes inside.
Okay.
So I'm going to load it underwater.
Okay.
Yeah, splash it, Srija. So now the whole assembly is loaded on to the
So the wire that you have placed through the fenestration is just if you have to go and balloon this once you have deployed the device, correct?
Actually, in fact, even otherwise I will balloon it. The reason is to make things coaxial. Yeah, at this point, Dr.
To make things complicated. To make things complicated.
Okay.
Shiva, is the patient in sinus rhythm or has some form of atrial tachycardia?
The patient had an atrial flutter, and we gave metoprolol, and right now is on a 2:1 AV nodal block. Currently, we are giving amiodarone as an infusion to achieve a medical cardioversion of this flutter. She was in sinus rhythm.
But if it doesn't get...
I will
so
cardiovert.
Would you not want to convert this rhythm?
I will cardiovert if...
would you not want to convert this... go on.
An additional reason for fenestration, I want to mention it.
Yes.
There's an additional reason for fenestration.
What's the additional reason?
The atrial fibrillation or the atrial fluttering.
Or in case you electrophysiologists need it.
Yeah.
Because, make it flat.
And you have to consider why...
You hadn't thought of it before, had you? Now you have.
No. That is... you have to consider why it becomes the ASD patient symptomatic.
Yeah.
And he becomes symptomatic because of arrhythmias. He becomes symptomatic when he has a pulmonary hypertension or diastolic dysfunction of the left ventricle.
So you're doing this largely with ICE catheter guidance or a combined fluoroscopy and ICE?
Combined fluoroscopy and take away our pictures. Show the fluoroscopy.
Yeah.
Take the camera out. Okay.
Yeah, thank you.
Yeah. Now deploy the RA disc.
So at the moment, the left atrial disc is round. Ish.
Yeah. Yeah. Now I want a little bit better confirmation of the ASD device. So.
Yeah. So there's something preventing it from becoming a flat disc.
So what part of it is maybe due to the wire also.
The wire and the...
Yeah, exactly.
Yeah. So I will just get it a little bit more aligned, and then I am just pulling the wire so that it is free in the left atrium.
Here it goes. It's flat now.
Yeah.
That's the wire.
Maybe the fenestration doesn't want to stay open. It says it's not needed.
Possible, yeah.
You know?
We can't see the discs very well on fluoro, but I think they're a bit flatter, aren't they?
I think the left disc is much flatter now,
Yeah.
Shiva.
Flatter, yeah. So
As you
now
pull the wire back.
I'm just getting the ice probe bit better.
Because you can really flatten it by putting a round balloon over the wire onto the left atrium and pull it back.
Yeah, right now the disc is configured well.
Yeah. So what do you think? We haven't got a really good ice picture.
Yeah, so actually there is some, the sheath is tight for me. It's a 10 French Acunav system, and I am on a tighter groin sheath. I'll try to sort this out.
Okay.
So the device configuration is good now.
Yeah.
Perhaps you could give us a transthoracic picture too when you finished.
Sure.
Shiva, we are just a little bit in time crunch.
Okay.
In about 2 minutes, we'll have to go back to 10.
Okay.
So if you want to show us
okay,
something in the next 2 minutes, that'll be awesome.
I will just I'll get the pictures. You go to tin and come back.
Okay, we'll go to tin because your case, I think there are a few more questions people will ask. So let's go to tin.
Put a Mustang through this.
Shiva, we see your pictures. Shiva?
Yeah. Are you? See, I will show the two previous pictures. Fluoro previous.
Yeah. So
fluoro.
We're back with you.
Previous fluoro. Previous fluoro. Previous. Yeah. So what we did was we aligned the fenestration across with a balloon. Next picture. So then the next picture. Next. Now we have taken out the balloon out. Show the fenestration on the echo, Uma, color.
So this is what size balloon and what type of balloon?
It's a Boston Scientific Mustang 7 millimeter balloon.
7, okay.
Okay.
And what are you trying to do? Just making sure that the fenestration is circular?
Trying to make the left atrial part of the fenestration and right atrial part of the fenestration come coaxial to each other.
I see, okay.
Shiva, there is a significant increase in the tricuspid regurg. You think?
There is the same, Dr. Bharat. We are not close to the tricuspid valve. Take out
no, not because of that. Not because of that. Sometimes atrial arrhythmias can also do it. It's not necessarily
that
related
was
to
there before as well, wasn't it?
Yeah. There was a elevated right atrial pressure of 14 millimeters prior to the procedure. And right now, I'm going to show you a pulmonary artery pressure.
Okay.
Put a wire. The problem that I had with the intracardiac echo shack was a 10 French sheath which was going through the left groin. Your hand is getting exposed. Take the hand, sir. Which was giving a lot of resistance to my manipulations. So I am planning to upsize the groin sheath. But since that is going to take a little while, I will show you the PA pressure.
Yeah, PA pressure. Milad.
What's the rationale behind coaxial position of the fenestration? I couldn't understand it.
Okay, so the question here is that Milad didn't understand your coaxial position of the fenestration.
In the past,
can you explain it a bit more?
Yeah, in the past when we have fenestrated by customizing across an Amplatzer device, we have realized that while we are making the fenestration, the left atrial and right atrial holes will be aligned properly. But you load it into a sheath, push it back, they will go off track. So, right now get a picture. So we have understood that if we try to make it coaxial, it's slightly better to keep a better alignment of the two holes. Hemodynamics live.
So
Hemodynamics
anyway,
live. Hemodynamics.
So one of the reasons initially in 2004 when we did the first fenestration actually with Amplify, remember the fenestration has to go through the right disc, the waist, and the left disc, right? So once by the time you put the device in, the alignment is not good. So in fact, we had
Camera
intense
out, echo.
So
Camera out, echo.
hemodynamics. Thanks to the hemodynamics.
Yeah.
PA pressures are impressive.
So now we have the clear indication for the fenestration. I want to repeat it. The diastolic pressure is higher than before. The resistance, the calculated resistance, was 7 to 8. Some surgeons say that is not suitable for operation. So now the patient needs maybe a drug treatment. But in the other side, every ASD patient with a pulmonary hypertension have a disposition, a genetic disposition for pulmonary hypertension. And to have this patient on the pop-off ventil for the right to left shunting, but even for left to right shunting if the left ventricle have a restriction, it's so enormous important. I can only say, I want to say it and I want to tell it in the world. You are in 80% you are right that you don't need it. But if you need it, you can be happy that you have it.
Dietmar, you are very emotional and I appreciate that, but still there is no need for this fenestration.
Well, I think there is. Yeah, this argument will carry on. We'll never have a solution to it. But
the only question I wanted to ask you, Shiva, is do you plan to convert this patient into sinus rhythm in the lab itself?
Right.
Because it has a lot of implications in terms of post-procedural management.
Right now, I'm going to cardiovert her electrically. Get her
before
back
you
to
release the device.
Exactly. Exactly. That is the that is always the protocol. We will before release we are going to cardiovert her. Sedation with ketamine 30 and midas 2.
So shall we
Shaq,
leave you at the moment?
Shaq, about 15 minutes later, I will show you an intracardiac echo picture with a larger femoral sheath.
All right, we'll come back and get an update. Very quickly, Hujjat Murtazia has got a comment or a question.
I have a question. Is possible we do contrast echo at now for showing the left to right or right to left shunt at now?
Well, they can see that on color at the moment.
See on color.
It is left-right shunting.
With a sheath, if you do a bubble study with a sheath where it is, you'll have some right and left shunting because it's directed at the fenestration.
And with the color, it's a pure left to right shunt.
Yep. Okay. So Shiva, we'll come back to you later on.
Sure.
Yep. But excellent demonstration of this case. Very educational indeed.
Okay. We can see the fluoro images.
Okay.
Can you hear us?
Yeah, I'm able to hear you well. Can you show the color across the fenestration? Shaq, are you here seeing the intracardiac echo? Echo bigger?
Can you make the echo picture bigger?
Yeah, echo bigger.
And take the fluoro off.
Yeah.
Perfect.
So
we see shunt for sure on you think this is through and through?
Yeah, through and through. I will give one contrast. Can you go without color live?
Shiva, that blue pressure is a aortic pressure or a pulmonary artery pressure?
It's a blue is the aortic pressure. What has happened is I gave amiodarone and metoprolol, so she continues to be in a junctional rhythm. Make the hemodynamics bigger. Hemodynamics bigger.
I would think that it may be worth, trying to give adequate fluids if RA pressures are low and maybe some inotropes to get the pressures a little up.
Yeah, we
I would be little uncomfortable if the patient is awake and the pressures are this low.
Bharat,
but if the patient is awake and talks to you, you don't have to.
No, Bharat, actually, no, what happened was for the DC version, I had given some midazolam.
Okay.
That midazolam reduced the pressure. And on the top of it, we also gave some beta blocker. Show the fenestration now.
Okay, I understand. I understand.
Okay, it shows the echo or fenestration color Doppler.
Yeah, echo bigger? Yeah. You are able to see the flow. Basically, since she is breathing in and out, there are times at which the fenestration comes in picture and then times at which the fenestration goes out. You are able to see the hole in the left atrial disc, a round circular hole.
Shiva, I'd see a lot of flow inside the discs.
Yeah.
Yeah.
You know, I mean, I'm not, you know, I mean, I think I agree with you that there is definitely has to be some left to right flow or shunting through the, but it may be very difficult because they are not aligned.
You were looking with transthoracic echo, sometimes either transthoracic or transesophageal.
Can you see that now?
Gives you better flow.
Make the picture bigger. Can you see that on the corner?
I mean, we see on the right side.
Yeah.
Kevin has a comment. Go ahead, Kevin.
Yeah. I wonder where you're sort of wondering about the alignment of the discs, you know, with your warranting, whether you'd actually be better to put an atrial flow restrictor in the fenestration and line it up. I think a stent, which I think people have done, probably protrudes a bit too much in these cases, but you have access to the atrial flow restrictor.
Reduce the zoom.
And they probably fit in quite nicely in these devices.
Yeah. We actually put Corey stents inside these when we started.
Did you give epinephrine?
But they're going to jut out a lot.
Okay, but you're right. I mean, flow restrictor may be better.
Shiva, did you give epinephrine a little bit?
No, I gave atropine.
20.
Atropine.
I would give epinephrine, not atropine.
We should move otherwise.
Because the patient have a very low pressure and a heart rate.
Shiva, I think we have demonstrated the fenestration. We could leave you alone while you are able to improve our pressures, and we can come back to you when you have another case.
Sure.
We can go back to our talks if that's okay with you.
Sure.
Okay.
Sure.
All right.
Sure.
Thank you
Thank
very much. Okay. Shiva, you're live.
Zahid, we had metoprolol and amiodarone induced sinus bradycardia with junctional rhythm. Right now, then the patient is on and off, coming back into sinus rhythm. You can see that there are times at which she is in junction, the times at which she is coming back to sinus. The pulmonary artery pressure is about 53 mean, and the aorta is 97 mean. The intracardiac echo is showing the left-right flows, and we are just getting ready to release the device.
Okay. So, I mean, I think you see better flow on echo now. I know we don't see the left side, but definitely it shows that the fenestration is open, because there is definitely left to right shunt.
Yeah. The rhythm part, if you look at the ECG, make the ECG bigger. ECG bigger. So she comes back to sinus rhythm occasionally, but stays in. See, there are the second and third beat are sinus. So she's yet to fully come back from the effect of amiodarone and beta blocker. So I'm going to release.
What medication?
Yeah. No.
Ismar has a question.
Shiva.
Yes.
Super good job. My question is, which drugs did you use for resuscitation the patient? And the second question is, what is the gradient across fenestration? You see a relative high flow.
Yeah, okay.
So,
put the Doppler.
and what is the right atrial pressure, and to estimate the left atrial pressure? And I think the lady is young, but maybe is she...
Freeze it. Yeah. See, the intraatrial gradient is less than 1 millimeters of mercury.
It's 4.
Yeah,
okay.
Little less than
so
4.
The left atrial pressure is 4 millimeter higher than the right. What is the right atrial pressure now?
See, I have to take out the ICE catheter because there is a leak of the hemostatic valve. So if I take out the ICE catheter, then I can get you the right atrial pressure.
Yes. This fenestration has a good chance for resuscitation if you have a right failing as a left heart failing, or a combination of both. So I guess, and it is very nice to show this color flow
fluorobic
for monitoring, even in a critical situation. It's a very nice tool.
Fluorobic.
Okay. Any other questions from the audience? Comments?
So the device is released now.
Shiva, Jay has a question or a comment.
Yeah.
So
there was some discussion about the fenestration is needed or not in this patient, but in many patients with severe pulmonary arterial hypertension, the patient may show intermittent aggravation according to the respiratory disease. Or in this patient, there was some atrial arrhythmia. The patient developed atrial arrhythmia. The pulmonary arterial pressure may aggravate. So also exercise may induce some aggravation of pulmonary arterial hypertension. So for the patient's safety, this kind of patient, I think definitely fenestration is needed.
Okay, thank you. Go ahead.
Okay. Just a simple comment for Shiva regarding when the device takes a cobra shape in the left side.
Yeah.
So maybe due to undersizing the sheath or keeping the device for longer time in the sheath. But most of the time we use balloon and we don't succeed to fix it. And we found it useful to pass catheter and tip deflector and fix it by tip deflected catheter.
Show the right atrial pressure.
Did you hear the question? Or?
Yeah. Tip deflector for changing the profile of the device.
Yeah, to reform the device and to fix the cobra shape, or cobra or the abnormal position of the left atrial disc. Sometimes it takes funny shape. So we used before balloons and we failed, but the tip deflector is fast. In a catheter, Judkins catheter and tip deflector, and put it behind it and fix it. It's faster. We found it faster than the balloon.
Okay.
Thank you. Shiva, show us the right atrial pressure,
This is
and then
right now.
if it's okay,
atrial pressure bigger. Right atrial pressure bigger. This is the right atrial pressure live. It's 19 millimeters of mercury. Zahid, what do you feel? Is fenestration a good option, or is fenestration like you would have closed fully?
I don't know, Shiva. The hemodynamics are not very stable. You see, the systemic pressure is back to 90.
Yeah.
PA pressures are back to 21. So
No. That is not PA pressure. That is right atrial pressure.
Oh, sorry. I'm so sorry.
PA pressure is 48
but the systemic pressure is 9.
Yeah. You see, Dr. Bharat, still we have not got this sinus rhythm.
Yeah, that is what my worry is. And my next question to you is, since she is going into intermittent atrial fibrillation, your post-procedural protocol for antiplatelets or anticoagulation is going to be anything different than normal?
Yeah, actually I give dual antiplatelets for all the fenestrated ASD device. We have done 5 of them so far, and all of them we are maintaining on aspirin plus Plavix, and we are not stopping them at the end of 1 year. The longest patency is a patient with 3 years, and it is still continuing to be patent. The patient has moderate levels of pulmonary artery hypertension, around 60 to 70 PA pressure even now, is on pulmonary vasodilator as well. The problem that we are having in this particular patient is possibly a drug-induced sinus suppression. See, still she is in a junctional rhythm. She has not come back to a stable sinus rhythm. It's not atrial fibrillation, it is junctional rhythm.
Okay. Yeah, Siva, any last thoughts? If you're done, we're going to leave you with excellent demonstration of 2 good cases that you showed us, 3 actually. And if you have another case in the next 40 minutes, we'll be happy to come back to you.
No,
any last word for you?
My next presentation is for the coarctation session. So nothing more for the pulmonary hypertension.
Okay, sounds good. Thank you very much.
Thank you.
Okay.
Remove it now.